At the beginning of the pandemic, I had the honor of putting together a review with Mejia Nolan. She's the medical student at Harvard Medical School. And we were asked by the journal to think of neurology. Again, I'm a neurologist by training. What was coming out in the literature that pointed to disparities? And, across the board, what we witnessed was systemic racism and segregation of resources leading to inequity. And so, for example, when you look at data from people cared for acute stroke across the United States and Canada with COVID, people who identified as Black were twice as likely to die from that acute stroke. And when you try to piece out the pathways to that, it seemed that there was a structural segregation of who ended up at what hospital and what resources they had for acute stroke care, like thrombolysis and thrombectomy. There was data too about people who had neurologic diseases like Parkinson's disease and were trying to navigate a health system in the midst of the pandemic, and how there were gaps, again, systemic gaps in access to digital technology that required, that was really an important aspect for them to be able to get refills for their medications, to connect with their doctor for patient visits and so on. In addition, I think, there's an important part here of the lived experience that people have had in our system for decades, right? And how everyone at the beginning of the pandemic was less likely to come to emergency rooms for acute needs. But this was disproportionately people who identify as Black or Latino. And so in the neurology literature early on, there were less people showing up for acute stroke care. And when you looked at, well, who were these patients, many more of them identified as Black. And so all of these, things that we have in the diagram here come together to disparities, whether it's delays in diagnosis, delays in treatments or mistreatments, and at the end, death. Now, Claudia and I were talking earlier this week about cities and geography and how that played a role. And this is not specific to the COVID-19 pandemic. Anyone identify the subway line here? Chicago, yeah, and what about it? Have you seen maps like this before? Yeah, so people are nodding. If someone could chip in, what about this map? Yeah, go ahead.
We went over this in one of my classes and just showing that, like, if you get on a subway and you travel down the blue line, the life expectancy, changes based on what neighborhood you're in, and that could just be explained by the fact that you're changing locations.
Right.
It's like structural based on what happens.
Anyone here live in Chicago? Yeah, so what about it? So you're right there, and tell us more about the neighborhoods, if you don't mind. Like, why the change? Why, if you live in the Loop, if your life expectancy is 85 versus somewhere here in the middle, it's 69? No, there was someone in the back. Thank you.
Because you're rich if you live in what's called the Gold Coast, which is the Loop, which is right in the middle of downtown. Then as you go west, it gets into more Black and brown neighborhoods. And you keep going, and the incomes are lower, more essential workers, and so that they're out and about and COVID, and you're going to have less and less resources. Right. You keep going, and the reason at the end of the blue line it begins to pick up is because the end of the blue line is in the suburbs, and you begin to have some higher income and some lighter neighborhoods.
That's right. That's right. And if you haven't, if you go online, you'll find a map like this of Boston, of Washington, D.C., of the place you live. And so this is not unique to Chicago. If you look at it at a country level, there's also segregation of health outcomes. And so again, as a neurologist, I'm showing you an example connected to stroke. Anyone familiar with the stroke belt? Okay, yeah, I see someone nod their head. So, yeah, what about the stroke belt, if you don't mind? Yeah, maybe someone behind you, you were nodding your head about the stroke belt. That purple area. Yeah, no, maybe.
I was nodding.
Yeah, tell us. Yeah, so what about the stroke belt?
The stroke belt is in the geographical southeast.
Yeah.
It has a high population of individuals who identify as Black. do oftentimes. It's also part of the country where there's limited access to healthcare, particularly with Medicaid expansion and other limited access to social determinants of health, which are inextricably linked to health, and I think likely explain the higher prevalence of stroke rates.
That's right, that's right. So thank you for that, because I hope everyone could hear this explanation, because the stroke belt is not a coincidence. People in this area, the darker purple area, are more likely to suffer strokes at a younger age, have more than one stroke, die of a stroke, have greater disability of a stroke. And when you look at the pathways to these inequities, they are very connected to access to other things like education and wealth, health insurance. And so here we're in Boston. Anyone from Boston? Okay, a couple people. Okay, I live here in Boston. And for all of you visiting, I hope you're enjoying this city. I think it's a place with beautiful history, beautiful built environment, a tremendously diverse community, yet also inequity. And this is a map of COVID. And this is just Boston, so not greater Boston, but the city of Boston and its neighborhoods. And this is earlier in the pandemic, but you can see that there are areas there that are darker purple, and those are the areas most affected by COVID-19. Those are also the same areas of the city with the highest proportion of people who identify as Black or Latino, and those are the same areas with the highest proportion of poverty levels. Now, if you go to the Boston Globe a few years ago, they had a series on inequality in Boston. And they talked about data on socioeconomics, and I apologize for the small print here. But what you can see on the top graph is that in the city of Boston, if you identify as white, your income is in the six figures, close to $200,000. If you identify as Latino or Black, your income is around $20,000 a year. Now, this is income, right? This is what you make a year. The graphs in the bottom are wealth, what you make, but also what you owe, all pulled together. And wealth for the average Bostonian who identifies as white is $250K. And the Boston Globe piece got a lot of traction by a number of $8. And that $8 was the wealth of a Bostonian who identified as Black and who was born in Boston. You can see other small graphs there, and there are people who identify as Black from the Caribbean, for example, and people at the end who identify as Hispanic. And so you start to see the geographic with the individual, and again, all of that leading to disparities. If we take that to the macro level, if we look at the US as a whole, you can see here some information about poverty rates and how people who identify as Black or Latino, people who are not citizens, and people with low education and treatment tend to have the greatest poverty rates. Also, health insurance, and this is the topic of today, right? If you look at who is uninsured, and this is data from 2019, you can see that people often are working one or more jobs, and the family incomes are actually quite diverse, but the racial ethnic distribution is not equal, right? You can see a great burden among Black and Hispanic non-elderly people in the US. And here's, when I look at the stroke belt, it's not a perfect match, but to your point about insurance, here's the map down at the bottom where you can see the states in green are states that have more than 12% of people who are uninsured, adults who are uninsured. And we know that insurance matters, right? If someone's not insured, they're having to make very hard decisions about, making an appointment with a doctor, or even having a doctor, or maybe they do have a doctor, but they won't be able to fill their prescription or get the treatment that was recommended. So we have some examples of some of the successes during the pandemic and some of the challenges, but we wanted to give everyone a little bit of time here to talk with people around you about what has gone really not well in the pandemic, what have been some good lessons that we need to keep and kind of nurture for the future. And so we'll give everyone maybe 5 minutes. What do you say, Claudia? 10 minutes, let's do that. So pick a neighbor or a group of neighbors. And I think if you don't know them, if they're from a different place in the country, even better. To talk about, what have you observed? What happened in your community? What have you observed at a national level? And what are some good pearls that we need to take moving forward?
Yeah, so part of this is we want to have a conversation about the lessons from COVID and preparation for the next pandemic. And, coming from Chicago and Cook County, so we had to look at dealing with people in the jail, as well as folks who were in our ambulatory setting and trying to get them to benefit once we had a vaccine available, but also in terms of providing access to healthcare, and then in the hospital setting. So we want to have a dialogue about that. We think if people can talk a little bit, the person next to you, for about 10 minutes, and then we're going to come back and talk about what we think we learned and what we can use to apply going forward. Okay. Okay. Let's come back and share some of our shared experiences. I was in Cook County. So, Nicte and I have been talking, so one of the things that we had problems with is that I think public health failed us miserably, and that's not to direct at any particular individual, but the messaging wasn't clear, and the messaging became so politicized that we eroded trust. So we in the past counted on public health to tell us what was happening, and sometimes there was evolving information, and we were waffling. I know I can think about where from Chicago. So Chicago has the Chicago Department of Public Health, the Cook County Department of Public Health, and the Illinois Department of Public Health. So, and they try not to stumble over each other, right? In that if one came out with a message and they want to say something that was conflicting. But think about COVID and how it evolved. That initially we told people they didn't need to wear masks. We knew this was a respiratory infection. We knew we had for respiratory infections, we usually tell people, for example, if you have someone who has tuberculosis, we tell them to wear a mask. We had the doctors who taking care of patients with tuberculosis that they wear an N95 when they go into the room with the patient. But we also knew that we didn't have enough masks. And so we wanted to make sure that we had enough masks for healthcare workers. So therefore we told the public. And then they could see on the news, they could see people in China walking around wearing masks. And we said, you don't need to wear a mask. And then we said, you should wear a mask. And when we told people that was something that was on another part of the world, they didn't have to work. And then all of a sudden we said, you have to stay home. And we became more concerned about the political consequences of the messaging than we were about the public health issues. Because when you tell people they have to stay home, they can't earn a living. And so there was a lot of pressure from economic pressure. And we had, at the beginning of the pandemic administration, that was not necessarily focused on transparency and truth, but was really more focused on meeting the needs of particular special interest groups. So you guys had a chance to talk to each other. What are some of the things that you think didn't go well that we did for them? Yeah.
I think you brought up a good point in terms of changing messaging. Like, I think that's something that really diminished people's trust in the system and their ability to, try to be a responsible citizen and do the right thing. And I think part of that's unavoidable. Like, science is supposed to be a field where you update your best practices and your advice and your, standard of care based on new information. So some of that is not like a hypocrisy. Some of that is just as we learned more, we knew what was more prudent, you know. But at the same time, there were lots of failures made by people that were giving public statements, giving public advice about how to be safe and, you know, do this, don't do this, or, you know, the CDC making promises that they couldn't have kept, saying, don't worry, we'll be back to normal in 2 weeks. That was like very foolish of them to do. And, you know, people would say to me, you can't trust them, they keep telling us different things. And, you know, there's an extent to which like, they have a point. We didn't earn their trust in a lot of ways, or we sort of misused the trust. So I have a lot of empathy for people that, you know, no one could have predicted the way things would go. Lots of people, I think, were just doing what they thought was best at the time. But it's very easy to look back and say, okay, next time something like this happens, how can we be more consistent in messaging? How can we communicate to people, you know, we're working with the information we have, or, you know, this is the advice for now, it might change later, we need more data.
Well, so there's an important point there, is transparency, is acknowledging what we don't know, right? So we didn't, we came out with very emphatic statements in some areas without actually having the information we might want. What else? Yeah.
I think one of the failures is it became sort of this moral issue where we had villains and heroes. And initially, if you were infected, it became a matter of let's investigate how this person was infected. Oh, they're a frontline worker, let's label them a hero. They're not a frontline worker. Oh, now it's villanified. And even to this day, you still see people who post, oh, this is my 12th COVID test, I'm negative. They're excited. That people have told me, patients, friends, colleagues, who have said, oh man, I just came out positive for COVID. What are people gonna think? I went to see my family. Am I gonna be blamed for seeing my family on Thanksgiving? What am I gonna do? So I think part of the issue is it became, it became a moral issue, and that's on both sides.
So we vilify people who had COVID.
Yes, and we celebrated those who did not, and we also celebrated how you acquired COVID.
Yeah.
Well, I mean, one thing that I'm still waiting for is for our government to actually have a open and honest presentation about the strategic mistakes and the successes that took place that can really give people a more of an accounting and a sense of history to it, because the Trump administration really has blood on its hands when it comes to how they handle the pandemic. But, you know, those failures haven't really been presented back to people living in the US. So,
But the problem there, and you almost defined it right there, is that it becomes so politicized that a presentation or release a report about failures will be viewed as slamming one administration as opposed to another. And that immediately gets into whether it's because they were Republicans. Because Ron DeSantis, you know, from Florida is saying, hey, I opened up the state of Florida, or Georgia is saying, we did right by people because were we wrong or were we right in terms of allowing people to go back to living their normal lives. It's a whole thing, you know, like we're all wearing masks, but majority of folks are not wearing masks anymore. And so is that wrong or is that right?
I mean, I don't want to put it on one person about what they do or don't do. That's another problem with the pandemic, is that, you know, in the beginning of the pandemic, folks who are poor or living in multi-generational households were like people who were dying the most right off the bat. And there was a moral component, you know, that was coming into being a responsible citizen versus a not responsible. That goes back to the theory of the public health system. It's not about putting responsibility on individual people. That's, you know, so much as having a unified policy and a clear vision for how to move forward.
So what do people think worked? What was good? What do we do right? Yeah.
This is a little bit tangential, but I have helped with research on seniors who access charitable food institutions in Dallas. One of the things that was really improved their living situation was that SNAP was expanded so that you could get the maximum SNAP benefits for your household. And that actually reduced food insecurity in many cases from pre-pandemic levels. So those kind of, it kind of helped people deal with the, not just the direct like health impacts, but
The consequences.
the consequences of the pandemic. And especially, that's especially helpful for populations who are less insulated against.
We're more vulnerable, right? You had no reserves.
Yeah.
What else?
Well, I think the technology really helped us because it showed the disparity in what households had internet. Everyone in this room who's pretty much middle class, probably assumes that, well, I wouldn't say all, but will assume that everybody's got the internet, and everyone's got a smartphone, and everyone's got a television. When some people don't even have electricity because they can't even pay the electrical bill, it takes electricity to run these things. But this was a game changer because, I just told my colleague here, I was able to communicate with my patients for the first time as a dentist via phone. And it was like eye-opening. I mean, all these years I've been seeing people for post-op observations and have to come in, shut in for their jobs, and soon they would put aside an hour for something that take them 10 minutes to do, to observe and look at their teeth. And that was really nicely going. Whereas this, I can look at their house, they can take a picture or video it and send it to me. I can look at it, call them back and talk. So that was game changing in a good way. But like I said, it showed the infrastructure of the United States was poor because there's a lack of communication through the internet for that stroke belt people, and all those poor, disenfranchised, blacks, browns, poor people, poor whites, who don't have internet access to get the information. And this was critical.
Right, so you alluded to something important. So one of the things that came out of COVID was telehealth, right?
Right.
I mean, telehealth was there before, but evolved. But the disparities persisted, right?
Exactly.
So we turned on a dime at Cook County. We went from in-person visits, we shut down all the clinics. And within a month, we had turned on telehealth. We had a telehealth platform. And then it turned out that 90% of the telehealth visits were a phone call.
Right.
There was no video.
Right.
And so what we were told was that, well, it's because the patients we serve are poor or they're not sophisticated and they can't access the video. Well, flash forward a year and we still have that issue, and we found out it wasn't the patient, it was the platform. That we didn't have computers in every exam. We had these wide terminals which were not full computers. And they didn't have the memory to support the video. So when the video didn't come up, it wasn't the patient's fault. It may have been, but it was just as much, we were just as culpable in terms of the platform. And so, while initially the patients were very excited that we were calling them to see how they were doing, but after a year, they were pissed off because some of them wanted to be seen. And so that played out across the country in terms of disparity. Who was able to access telehealth, who was able to benefit from it. I mean, to this day, we have patients who still don't feel comfortable coming back to be seen in person because there's anxiety and fear about COVID. But, there were a number of things that we did. You talked about technology. We rolled out that vaccine incredibly fast, right? But the reality is that virus, that coronavirus, very similar to, same family as Ebola. We've been working on that vaccine for years. That platform we've been working on for years. But because of the messaging, a lot of people didn't trust it. They thought it had come out too quick, just like you talked about the security person in your hospital said, well, because the hospital mandated, you got vaccinated. But they resented it because they felt that it was something that was being shoved down their throat. I'll say that we tried to provide access to vaccines. We opened up these mass vaccination sites. And we also offered vaccine at every one of our clinics. And a funny thing happened. You looked at that transit map and you saw the area where we had life expectancy of 69. So that's in a predominantly black area, right? They had never seen different white people when they started off the vaccine. And they said, where did they all come from? They came from the suburbs because we were offering vaccines and they wanted to get vaccinated. But our patients who got care at that clinic didn't come in to get vaccinated. There was no trust. And trust is about the message and the messenger. Who was talking to them about vaccine? And what were we saying about vaccine? And so I always say it's about meeting people where they are. We did not meet people where they were. We did not talk to our patients, give our patients trusted messengers that the vaccine was available, that it was safe, and that it was going to help. And there was a lot of noise on the internet. There were a lot of folks telling them why it wasn't something safe or something they should do. And it's just like everything else that we've learned in terms of taking care of population. The messaging matters and the messenger matters. And if we're going to learn from this, we have to remember that in terms of messaging. So, who has other experiences with vaccination? Yeah.
Well, I just want to bring up a point. So something that I discussed in our group is that in preparing for the next pandemic, I think the scope of what medicine doctors actually get involved in really has to expand to social determinants of growth. And some successes in this past pandemic actually have been COVID vaccine uptake, although it did take a while for the vaccine to be rolled out. But I just wanted to point out, so amongst indigenous peoples of the United States, vaccine uptake was the highest per population, but outcomes with COVID infections were also the worst. And so I feel like we have to expand the scope of our practice and the scope of our advocacy to think much more beyond these vertical initiatives and really start to integrate social determinants and public health in our day-to-day practice in preparation for the next pandemic.
Yeah.
This is kind of, this is preliminary research, but from those interviews, the population, and I think it was 8% and with the talk of, vaccine hesitancy among people of color, there was actually very few people who were vaccine hesitant in our sample. But there was a relatively small amount of people who were vaccinated. So a lot of people talked about, like I remember one of them mentioned, I remember Tuskegee and I understand all that, but I don't even see my children. So and a lot of people who wanted to get vaccinated but couldn't. They wanted to because they could see their family and they had more freedom, leave the house, but they were not able to because of lack of transportation, or they were confused or had signed up for like their son or daughter to sign them up for them because they didn't have access to internet and didn't know what to do on the internet. So it was like more access things as a person.
Yeah, I think that there was a lot of people wanting to attribute it to vaccine hesitancy when there were logistics that were very problematic for folks. And one of the things that was going, first of all, trusted messengers talking in churches, talking in community groups, but also making vaccines available, going to people's homes, going into the neighborhoods.
You had your hands up too.
Yeah, going back to messaging and having trusted messengers, I've actually been hearing a lot of Spotify ads lately. I don't know if it is during COVID, but they're about getting vaccinated, and the two women who speak in them, one of them is a grandmother who's Black, the other is a grandmother who's Latina, and so they the two different ads kind of take different approaches to say why you should get vaccinated or play on the community values from the pose of a grandmother, and so I thought those were really cool.
All right, yes, sir.
And I think you know, I apologize if I offend anyone, but I think as healthcare providers, medical students, preceptors, practicing physicians, we forget how educated we are compared to the rest of the population. So I think the science behind the vaccine information was completely lost. And like I mentioned before, and other people have mentioned, it became a moral and a political issue. And I think about that a lot because now being in clinic, and I'm talking to a patient about carbohydrates. You know, everyone in the room can tell you the structure, can tell you what a carbohydrate is, can tell you the amount of calories. I have patients who are like, what's a carbohydrate? And I'm thinking, sometimes, you know, it's a bit, I'm thinking, oh, geez, you're 6 years old, you know what a carbohydrate is? But I think we forget that. We forget that they don't have the same opportunities that we had. They don't have the same level of education. They don't have the same training. And that messaging in terms of, oh, what is COVID? Is that a virus, a bacteria? Is that an animal? You know, what is COVID? What is this vaccine? How is it going to benefit me? And the times that we have the opportunity to actually sit down with patients and be like, no, that's not a side effect. This is what you should expect. They're like, oh, okay. They understand a little more because most of their information is coming from other people who don't know, who are just posting, or I apologize, shit posting online, or they get their information from certain news sources that aren't the most credible. So they're being misled. And I think it's our job as students, healthcare providers, to sit down and understand that, okay, we're going to simplify this for you. We're going to transmit that knowledge into a digestible form.
Yeah. Yeah.
I'm just trying to make sense of all this and contribute something. I think part of what a number of these comments we're describing is there's a huge vacuum that's created by lack of, for example, primary care and trusted community clinics. And this vacuum got filled in by a lot of things that some were creative and positive, but a lot of negative things. So in other words, I have to admit I was discouraged as a primary care doctor when patients who I had long relationships with, medium long, not as long as I can county.
We refuse to get vaccinated.
Yeah, but really over time, we could get through to some of them we couldn't. But clearly, these are sort of symptoms of deeper problems in terms of trust, in terms of disparities of risk that people have, even in terms of education. People who haven't had education to learn how to sort out truth from fact, like basic statistics. People should be literate in a lot of that. So I just think we have to think about all the failings that these bad ideas have filled in. And so for the next pandemic, I think we need to be strengthening primary care. Unfortunately, I think primary care is falling apart. I mean, we'll see number of people getting out of being primary care. We even just heard about Canada. There's huge GP shortages. So we need to think about how we're going to recommit ourselves to building that part of that public health infrastructure back up, because it was already in trouble and it's really going over the edge.
So I'm going to pick on you, Rachel, because I know you have thoughts about some of the lessons for the senior health officers in the county at this time.
Yeah, I mean, all the things that you mentioned are certainly great areas and things that you did important. But there were also so many constraints on us doing things right. There's no one right. But there are all these political forces that didn't allow us to communicate the way we wanted to say the right things the way we wanted to. Because there's sort of this hierarchy. There's CDC, and then things trickle down to the state health departments and then to the local health departments. Then there's Chicago, that also has a direct line to CDC that bypasses the state. And then you find out that the CDC is really getting their messages. They might be thinking the right thing, or thinking outside the box, but they're not allowed to put those things in.
Yeah, you can't say that. You can't say, and so you say we're talking about, CDC has very strict. Someone was talking about, oh yeah, so Phil Bearhoff, white works for CDC, that you have no idea how scripted everything they say is. How you can't present anything without it being reviewed by higher ups, you know.
Well, right, and not only if you review by higher ups, it's, people forget that the CDC isn't the law. The CDC doesn't make regulations. The CDC only makes recommendations. And it's the states that have to put in place specific regulations. And then the locals, like my health department, I mean, my name was on all of these emergency orders, right, for the county level, that were more strict than the state. I couldn't be less strict, but I could be more strict than the state. But we sort of used our state cachet. But, you know, that's sort of like the stick, it's not the carrot. How do you engage people? You know, we tried to do what we're calling a hyper-local vaccination program, going into people's communities and talking at the churches and getting community groups involved, and realized that I think it did make an impact, but it was very slow. It's getting a few people in.
It took time, yeah.
Right, and so then we get dinged because our numbers don't look so flashy like the large mass sites, which got a lot of people in, but it's people coming in
From great
the
business.
far north suburbs, going to the north suburb, south suburbs where the black and brown people live, or into the city clinics, into the south side, you know, it's just, it ended up so illustrating the disparities and the segregation and the total lack of support of our critical essential workers.
You made me think, if I may add.
Yeah.
I grew up in Latin America. I went to medical school in Mexico and practiced as a primary care there for a year. And this balance between local and national, I think is something to really think through for the future. In Mexico, I'll give you an example. There's very high rates of vaccination for all vaccines. And they are, for decades, there have been national vaccination campaigns, National Vaccination Week. So it's something that as a country we're doing, it's something that all the community health centers are doing, the community health workers are doing house to house. And despite, you know, gaps in health literacy, for example, someone was mentioning, this is what we did as a community. Each community was contributing to the greater, this is the goal for this week as a country. And so you know, it's a balance, I know, but you know, you make me think too, one of the things I did was volunteer for the COVID response in my kids' school. And I was put in a subcommittee that had to do with buses. And, you know, for the kids who were riding the bus to school, what did we need to do so that they were safer or as safe as possible? And there were publications on the risk of COVID in a bus. And despite the data, the conversations would be very heated. This makes no sense. It should be 6 feet. They shouldn't have someone next to them. And you look at the data and say, but this study proves otherwise. And so again, thinking of the local decision-making versus the national and where you can synergize better, I think is I don't know,
Right,
something.
so that's one of the places where we fell down, because initially we talked about COVID being droplet spread. And everybody put up these plexiglass barriers and said, okay, well, this was gonna protect you, and we said there was something safe about 6 feet because, you know, the droplet wasn't going to occur. But then we realized, oh, it's aerosolized. And so plexiglass doesn't do a damn good for, you know, aerosolized spray, right? But we were very emphatic about it and then didn't know how to roll it back when we realized that. You know, so we actually won an award for a campaign, a vaccine campaign that we did, but we had a bunch of doctors of different origins, you know, Black, white, Latinx, Chinese, Polish, who talked about, who said, trust me. You know, you trust me, you know, to take care of your kids, you trust me when you're sick, and, you know, so I'm telling you, you need to get vaccinated, that's the only thing. And we you know, so we rolled out this massive campaign because they gave us $1 million and we put it all over, and then other health facilities across the country used it. I don't know that it made that much of a difference, you know, but the people who watched television thought that was great. That was cool. I mean, what it was really, you know, the hyper local thing that Rachel talked about is actually going to the neighborhood. And I'm going to tell you that we know better. So a county we wanted to do something, and this goes back years, do something about getting people to get screened, getting Black men screened for colon cancer. And that's just something that wasn't gonna happen. And so we did, we invited a bunch of barbers from the South Side, and we talked to them about colon cancer. We had them play with Play-Doh and show them what the, how it was and how to, and so that when they would get a client in the chair, they would talk to them about colon cancer. And it made a difference. It made a difference in folks getting screened. So then we did beauticians. So you got somebody in a nail salon or sitting for hours getting their hair done, and you talk to them about colon cancer, and they got screened. We did the same thing with oral cancer. It comes from having trusted messengers with a well thought out message. And we were looking for a splash in the pan that we could do quickly. Right. And we had already established the trust that people had in public health, because we told them, you don't need to wear a mask, you have to wear a mask. This is spread by droplets, 6 feet will protect you. This is aerosolized, no, 6 feet doesn't make a difference. If you're in the room, it's gonna spread. So the lessons for the next pandemic have to do with not trashing the trust that you have with patients. The lessons for the next pandemic is preparing that messaging and how you're going to deliver it. And it's not going to be a slick television commercial, right? Because that's not necessarily where people get information. We got more splash out of using the young folks who were influencers on TikTok and on Instagram. And by the way, I hate to break it to y'all, but nobody under 50 is on Facebook, okay? It's just not that. So we actually found that bringing those folks in and having them do videos got more hits, got more response, and got more questions. Established a dialogue, and that's what we needed, is a dialogue. Because you don't know what people are afraid of. You don't know why they aren't going. As you pointed out, it wasn't about hesitancy. It was about access. And there were other things, there were some concerns about injecting metal into your body. There were concerns, but you can't begin to address those things until people say them to you. Right. And so I think one of the huge lessons is how do we engage people on a more personal level about their health overall.
We have more slides. I don't know if we should kind of go through. It's in a way a summary of what everyone's been sharing. And maybe that part will help us close these 10 minutes. And so, this is just some images around equity and justice. And for the future, for moving forward, many of you said, there were so many failures that were structural. And we know that the system is set up in a way that it disadvantages some and not others. And so we really need to work towards justice to proactively improve the things that we know have not gone right. Someone over here talked about social determinants and really doctors being more proactive about taking a step beyond the walls of a clinic and really thinking of education and health insurance and governance and other things that matter to people. And maybe that will be part of building trust. We'll need to think about health equity, and these are just definitions by Robert Wood Johnson Foundation for everybody to have a just opportunity to be as healthy as possible. So again, doctors, clinicians, stepping beyond the usual concept of medicine and thinking about poverty and discrimination. And measuring, right? Because if we don't measure, we can't document what's wrong, and we can document the successes. So Claudia was talking about the beauticians and the barbers, and there's beautiful research about how impactful these type of interventions have been reversing disparities in many ways. This is from the CDC, so a recommendation, but it's a framework for action that they've used for other public health problems, and just to help us organize with some of the things that all of you have been sharing. We've talked about counseling and education, and I think that one is really, Claudia is really right on point, and all of you have been talking about what's the message, who is the messenger, how can we proactively build trust. Dr. Schiff here was saying, well, a lot of the primary cares have been retiring. That's been my experience as a specialist. My patients are telling me my primary care, who I trusted for 20 years, has now left, and I'm now primary care less. What do I do? And so how do you build trust in that kind of situation where we're in? Some of the data that everyone here talked about was about gaps in access to diagnostics, gaps in access to therapeutics, how hard it was to get to a vaccine. And I think that we need to be proactive. How are we distributing resources, and are we being equitable? Are we distributing the resources across those city maps, right? Are the hospitals and clinics in the places with people living less, are they having access to good diagnostics and treatments? The workforce diversity part, I think, is super important, and we haven't talked much about this, but it goes back to the message of the messenger. Who are the clinicians of the future, and do they really meet people where they are? At Mass General, one of the things that we noticed, and I know many hospitals face this, there was a sudden surge of people who spoke other languages. In our hospital, mainly Spanish, and our interpreter service office was not enough. And so one of the things that they had to do was pull clinicians who spoke Spanish, a Spanish language care group, which I was a part of. We were like 65 of us. And while it helped acutely, it's not a long-term solution. We need a more diverse, including like linguistically diverse clinical workforce. We were talking about vaccination, and that pyramid from the CDC, and as I should have mentioned, as you go down the pyramid, the things at the top are easier to do than some of the things at the bottom that need more time, more money, more investment, but all of them matter. And one of them is long-lasting protective interventions. And COVID is one of the few things where this is available, which there is a vaccine. And so for the future pandemics that have the access to a potential vaccine, we really need to think as a country and locally of how do we escalate vaccination campaigns much more effectively than what we do now, and really learn from some of the great organizations that occurred in many places in the US, whether it was Chicago or Philly or Boston, where people came together and partnered with communities to be more effective at reaching people where they were. We're here talking about health insurance, and I think that's a huge part that needs to change. You saw the data with regards to the pandemic and who was dying. We've also talked about telemedicine, and the telemedicine parts that I'd like to add. I've been doing telemedicine since 2014 through a grant with PCORI, and I care for people with Parkinson's disease. It's a very visual situation where I can help people through the screen effectively. And there's so many layers. This digital divide that exists in our country, where not everyone has equal access to the devices, but also broadband internet, is something we have to change. There has to be better policy. There has to be really an urgency. Some of the internet companies said, well, we're gonna offer free internet if you have a certain income. And they were not offering good broadband. So whenever it came time to do a visit by video, guess what? It wasn't working because it was not really suited for that. The other part is legislation around access to telehealth across state lines. And this is an ongoing issue. Right now, you have to be licensed in the states where you're providing telehealth. And so hospitals were offering these services, like in New England, where it's a very small geographic area. Many of us care for patients in New Hampshire, in Maine, in Vermont, and hospitals have had to invest in licensing physicians so that they can care for patients there. But there are several really interesting proposals out there on how you can escalate access to telehealth, including, for example, one where the benefit is expanded for people who have Medicare. And so if you all have Medicare as a patient, then, you know, the rules may be different and we could care for you across state lines. Again, going back to the socioeconomics and thinking beyond the walls of our clinics and thinking of investing in people and education resources and how well people are being paid, and thinking of those maps, how do we shape those maps up? It's not an easy question. So we have a couple minutes here. I'm grateful to be doing this with Dr. Fegan and with all of you. It's so exciting to hear people talking and connecting and really learning from each other about what has gone well, but what has not gone well, as we think of what the future may be.
Any questions? Yeah. And now for me.
It seems like a lot of what we're talking about with the messaging and building trusted professionals is like a lack of the ability to communicate like between physicians and patients. So do you think that there's any hope in medical education for there to be more emphasis on like how do you communicate and like workshops on that? Because right now it's obviously very focused on like this.
Oh, yeah, I love that question, you know, because some of the initials after my name have to do with being boarded in quality. And so I love this study done like 20 years ago where they interviewed patients and physicians, you know, a patient goes into the room, has a visit with the physician. And then after they come out of the room, they ask the patient what they think happened in the room. And they ask the physician what they think happened in the room. And it's such a vast, you know, gap. You know, patient, well, he yelled at me, you know, and they didn't hear anything that they got yelled at. Or, you know, the patient, the physician said, yes, I talked about diet, I talked about, you know, lifestyle modification. So that's got to start at the very basics. As we talk about the declining number of primary care providers, you know, there are a lot of reasons for that, but helping us get back to the communication piece and how we train primary care providers. I actually think that the primary care providers are going to be, in the future, going to be more APPs, more PAs and APRN, who spend more time talking and listening to patients than physicians have been necessarily trained to do. Most physicians make up their mind about what's going on with the patient within the first 30 seconds to 2 minutes if they're listening. I'm going to back to I have this gentleman back there.
On the subject of, you know, public health and going beyond physicians with helping reach folks in different communities, what are your thoughts on, or are you aware of, you know, real efforts to kind of create a public health service corps, you know, something along the lines of taking the idea of a promotora or like a community-based health worker who can provide important education at the
Well, so there's a huge movement, and there's a lot of grant dollars for it, but there's a huge movement across the country in terms of community health workers, like the Pomodoras who help with pregnant women, you know, teaching people in the community about health issues and having them to talk. So there's a lot, and she's telling me I have to stop now. But I think it was a good conversation, and I hope that we can continue to engage with